Welcome to the My Favorite Learners podcast, where pharmacology meets real-world anesthesia in a whole new way. Hi, I'm Chloe G. I'm here to shake up how we learn about drugs. No dry lectures, no endless memorization, just real conversations with CRNAs, pharmacology experts, and other healthcare pros who know their stuff. Whether you're a student, a seasoned provider, or just a pharmacology nerd, we're diving deep into the meds that make anesthesia happen. So grab your coffee, your curiosity, and let's talk drugs. Hello, my favorite learners, and welcome to another episode of our podcast, where we explore the science, stories, and strategies shaping the future of anesthesia and patient care. Today's episode is titled Volatile Anesthetics and Environmental Impact, and we're honored to be joined by Dr. Jessica Phillips, PhD, CRNA, a respected clinician, educator, and sustainability advocate in the world of nurse anesthesia. Dr. Phillips and I share a meaningful connection through one of the greats in anesthesia education, Dr. John Nagelhout, who mentored both of us in pharmacology and laid the foundation of our understanding of anesthetic agents. Building on that shared legacy, we take a deep dive into the pharmacokinetics of volatile anesthetic agents, exploring how these agents behave in our bodies and, more importantly, what happens after they leave the patient. Dr. Phillips brings a wealth of insight into our clinical choices and how they impact the environment. We discuss the carbon footprint of inhaled anesthetics, practical ways to reduce waste and emissions in the OR, and how each of us as providers can become stewards of sustainability without compromising patient safety. Whether you're a student, a seasoned CRNA, or anyone interested in the intersection of science and sustainability, this episode is packed with knowledge and inspiration. Let's get into it. Hello, my favorite learners. Welcome to our first guest on this podcast for pharmacology. I have Dr. Jessica Phillips here, PhD, CRNA. So thank you for being here, Dr. Phillips. We appreciate it and all of your knowledge. Can you just tell us about yourself and a little bit about why you decided to get your PhD in pharmacology? Like, who were your mentors and kind of how they impacted your journey along the way?
Yeah, so I have a couple degrees. So I was a second career in nursing. First, I did my bachelor's in psychology from University of Michigan, Ann Arbor. But their psychology department was also very heavy into physiology and kind of pharmacology, which is where my love first started developing. And then went on to Wayne State University, and I got my master's of science in anesthesia. And they had developed a new program with Wayne State Medical School, which really looked at CRNAs and compared us to other graduate learners. So for instance, MD students could get a PhD in a year and a half, 2 years after they graduate from their medical schools. And there was a couple people there that said CRNAs are also highly educated, advanced practice providers. So we want to give them the same opportunity. So they developed this pharmacology PhD through Wayne State Medical School, where a lot of the anesthesia credits were able to transfer. So instead of the traditional 90 credit PhD, I did 60 additional credits, and now it's down to 30 with our doctorate, to give CRNAs that opportunity to get that PhD in pharmacology from the medical school. So I was the inaugural student. I was very lucky to be presented with that opportunity. And mentor-wise, of course, Dr. Sokol Todi, who was the one who set that up at Wayne State's Medical School, is really a champion for CRNAs and giving us that opportunity. He was great. And then he did that with Dr. Prudential Worth and Dr. Mary Walczyk, who were our program director and assistant program director for Wayne State Nurse Anesthesia at the time. And then Dr. Tracy Baker, thankfully, took me into her lab. She accepted a full-time working CRNA and worked with my schedule. And she was the one who got me interested in the environmental impact of pharmaceuticals and kind of the transgenerational effects. So that was very, very cool. And then, of course, Dr. John Nagelhout had gone to Wayne State and taught me nurse anesthesia pharmacology. So he was still in touch with a lot of those people, and I had a lot of great conversations with him going into this.
Amazing. Yeah, I went to Kaiser Permanente School of Anesthesia, so he also taught us in person. Was very, very fortunate, and so sad about his passing. But the legacy that he left is pretty incredible to this day. So Well, thank you for sharing that. I want this podcast to be just not an opportunity for my students or anyone that's listening to learn about pharm, but also to see what CRNAs can do. And I didn't know that they had that PhD, so that's really interesting to learn myself. So that's awesome. Thank you for sharing that. So as the first part of this, we're going to kind of talk about how volatile agents move through the body, the pharmacokinetics of volatile anesthetic agents. So we're going to start with the basics. So it's going to be like a Q&A, professor to professor, I guess, with you being at the top, okay? Me being new. So when we inhale agents like sevoflurane, like can you talk about what's actually happening? Like how do we pick it up? How does it spread around? And then how do we eventually wake up from it?
Yeah, of course. So volatiles are very unique in that before you're in anesthesia, you have almost no experience with them, right? So it's always, when I first talk to it about them to my students, difficult to wrap their head around. So essentially, your lungs, since they're very vascular to bring in that oxygen, you're delivering that gas via those lungs, but it quickly diffuses into the bloodstream. So it's a very quick delivery system into the bloodstream, almost as quickly as giving someone an IV anesthetic if they're ventilating well. Once in the bloodstream, it's really the concentration of that anesthetic that travels to the brain and the central nervous system that matters the most. It will diffuse throughout other parts of the body as it goes back into the bloodstream, but having sevoflurane in your bones isn't going to put you to sleep, right?
Yeah.
So it's the brain that matters. And since those lungs and the brain are both very highly vasculature, you can easily correlate those two. Once in the brain, uh, all of your volatiles, your sevoflurane, isoflurane, desflurane, are GABA-mimetics in the brain. So they activate that inhibitory GABA G protein receptor, right? Voltage-gated chloride channel, and they flood the cells with chloride. It essentially hyperpolarizes so much it can't depolarize. You can't get any action potentials firing. So that's in the brain. The volatiles are a little different, unlike your propofol, your etomidate. They don't just activate those GABA channels, they also act in the spinal cord. So that's why it's not just the brain concentration, but it's that whole central nervous system concentration. So in the spinal cord, glycine receptors, those are very similar to GABA, right? Bind to that ligand-gated ion channel. It opens for chloride. The spinal cord hyperpolarizes, can't fire action potentials. It also antagonizes or inhibits those NMDA receptors. A lot of people know that is ketamine's kind of mechanism of action. All of your volatiles do that as well. So again, binds to the ion channel. You get an influx of calcium. Normally, it leads to excitation and firing. By blocking that, you don't get that action potential generated. And then last but not least, your sodium channels in your spinal cord, they also bind to those, so you don't get any of those neurons firing.
That's awesome. I remember Dr. Nagel used to say, if all else fails in anesthesia, if you're guessing a mechanism of action, GABA is a pretty good guess. So,
The main of almost all our anesthetics.
yeah, GABA receptors. So things like ventilation and cardiac output, what kind of impact do they have on our volatile anesthetic agents and how we go to sleep?
Yeah, so that's a great question. So first and foremost, if you don't get that gas to those lungs, it can't get to the brain. So ventilation is the first kind of parameter we look at. And I tell people to think of especially like your reserve volume and your minute ventilation. So if I'm taking fast breaths with low tidal volume and I have like 5 liters total in my lungs, that faster rate, even though it's a low volume, I quickly add up to 5 liters, right? Or you can do big breaths and small rate as long it's how much turnover you have in that lungs over 30 seconds, a minute, whatever your end goal is to get them to sleep. So that's why when we're putting someone to sleep with like an inhalation induction, we quickly take control of their breathing, and breathe quickly, right? 16 to 20 breaths per minute to really turn over those lungs quickly to build up the gas as quickly as we can. It's also why in pediatrics, children have a really low reserve, right? So for every like milliliter of tidal volume, they only have a milliliter of reserve, as opposed to adults, which is like 1 to like 2.5 ratio. Children, since they have less reserve, less gas not participating in exchange with the atmosphere, you fill up those lungs a lot quicker. So that's the first way. And then the second is you have to deliver what's in the lungs to the brain, right? But you want to keep it in the brain. That's kind of the caveat. If it's traveling quickly from the lungs to the brain, that's great. But the problem with high cardiac output is it also diffuses back out of the brain and is quickly carried away from the brain. So high cardiac output states don't really help you with your inhalation inductions because, yes, it gets to the brain quickly, but it goes away just as quickly. So it takes a much longer time to have a concentration stay in the brain.
Which kind of seems counterintuitive because you would think high cardiac output, you go to sleep faster, more effective, but it's kind of the opposite in that regard. So it's a very interesting concept for sure. So talking about, you did a great job talking about the whole pharmacokinetics. I love like the picture and visual that I got. Blood gas partial or partition coefficients are kind of intimidating to new learners because again, it is this new concept of volatile agents that we haven't really seen in our past nursing careers. So can you kind of break down what a like blood gas coefficient even means?
Yeah, so blood gas coefficient is just a ratio of how many molecules are staying in the alveoli or gas portion versus how many are in the bloodstream or going to the rest of the body. Now, again, you would think we want the bloodstream to pick it up and take it to the rest of the body. I want a higher number in that area, but you don't actually. It's the gas portion that's the most important of that because if it's staying in the lungs for a long time, it's probably staying in the brain for a long time, whatever's made it to the brain. So essentially, all you do with that ratio is it gives you the number of molecules in the blood versus one molecule in the gas. So you won't see like a 1-to-1, you'll see like 0.65 is the blood gas coefficient for sevoflurane. So all that means is 0.65 or just half a molecule of sevoflurane is in the blood for every one molecule in the alveoli, right? That's really good because it means it builds up much easier in the alveoli and therefore the brain than it does the bloodstream. So it has a much quicker onset. So essentially, blood gas coefficient is just showing you the onset, right? DES is even quicker. It's closer to 0.4. So 0.4 DES molecules in the bloodstream for every one in the alveoli. So the lower that blood gas coefficient, the faster your onset is going to be.
So it's almost like the theme of the volatile agents is, besides ventilation, is the opposite of what you would assume. So the lower the number, the faster the agent, and the opposite is true. The higher the number, the slower the agent. So it's interesting to kind of get those concepts down because, again, it is like such a new concept. But I love how you talked
I like
about
to
that.
think of it as kind of like a race, right? Like sevoflurane can get you to sleep in like 0.42 seconds. It's not 0.42 seconds, but that
Yeah.
molecule versus ISO takes longer, right? They're going to take a minute and a half to get you to sleep.
Yeah, that's a great way to put it. Like almost like a sprint time. Like how fast is it taking them to get to the finish line? I love that. The next topic we're going to talk about is MAC values. So mean alveolar concentration, a very important topic in volatile anesthetic agents. But it's again one of those abstract concepts, right? So can you talk about it like in real world terms? Like what is a MAC value in terms of each volatile anesthetic?
Yeah. So first, there's MAC, which is comparing them all to each other, the minimum alveolar concentrations, and then there's MAC of each individual agent, which makes it very confusing that we didn't pick two different terms. But we'll start with the comparison to each other. and then we'll kind of talk about the individual values and what they mean. So I like to think of, so first of all, the definition in anesthesia in MAC is that minimum alveolar concentration, or what percentage of the gas in the lungs, right, needs to be at to put 50% of the population to sleep enough for surgery that they won't like withdraw their arm when the surgeon makes an incision. Okay, so that's kind of what we're working with. Um, I like to think of it though as also like if you have noise canceling headphones, right? Or if you're drinking caffeine, like what volume of background noise, if you had noise canceling headphones on, right, would people still be distracted? All right, so like Mac is what effectively your headphones can cancel out. Or if you're talking caffeine, how many cups of coffee do I need to get through my day, right? Mac is how many cups of coffee I need to get through my day without yawning. Okay. Um, and then you kind of go from there. So that's just comparing the agents to each other, right? The Mac for an espresso shot would be a lot less, right? I don't need 10 shots of espresso to get through my day without yawning, compared to a regular cup of coffee. Maybe I need 3 or 4 of those cups. Okay. So that's how you're using them to compare to each other. So if I needed 3 cups of coffee to get through my day, maybe the Mac of coffee is 3 to reach that, right? 50% can get through their day without yawning. Espresso, maybe it's like 0.2. I just need a tiny little bit to get through my day. So you have 1 Mac, and 1 Mac of coffee would be 3 cups. 1 Mac of isoflurane is 1.2%. That's a very small amount of gas in those lungs you need for 50% of the population not to move to surgery. Versus DES, which is closer than 6%. It's much weaker, so you need a lot more percentage to reach that same threshold.
I love the coffee comparison. I'm a coffee drinker myself, so the caffeine, I'm like, okay, you're speaking my language. It's almost like potency of each thing, right? Like how much caffeine do I need? And then also like the dose of how much do I need to keep patients from moving. So it's a very good, I'm gonna have to steal that. That's a great analogy. I love the coffee. I feel like a lot of people can relate to caffeine, right? Especially in anesthesia
Right.
school. It's probably my
Right.
highest intake of caffeine. Yeah, in my
The
life.
4 a.m. Well, wake ups, the like everyone's like, oh yeah, okay, 1 cup of coffee was good, and now I need a lot of espresso to get
Yeah,
through
we're
my
at
day.
three minimum now at this point.
Yeah.
Exactly. So, what other types of things physiologically can impact the MAC values of our agents? Like, what makes them go up or down? What type of, like, either patient characteristics or environmental characteristics can affect that?
Yep. So if you look at really what Mac is trying to shut down is your your basal metabolic rate is kind of how I tell my students, because it wants you to be asleep, not conscious, not really, right, metabolizing anything, just settle that whole body down. So anything that's going to increase your basal metabolic rate, hyperthermia, increased thyroid hormone, disease processes like that, seizures, right? That is going to increase your MAC value because it's going to have to work that much harder to calm your brain down, calm that central nervous system down. Any of your like acute methamphetamine intoxication, right? Since that's kind of an upper, that would cause your MAC to be affected. Now, if you're a chronic, like alcohol user, I'm so sorry, Bella's
Oh,
barking
no,
here.
it's totally fine.
Um, if you're a chronic alcohol abuser, since alcohol affects those same GABA receptors, what will happen is your body doesn't really like constantly, right, receptors being agonized, turned on, doing their thing, so it'll downregulate and pull back receptors. Well, then you're going to need a higher dose because you got to find those receptors, right? And now it's like finding a needle in a haystack. One person looking for that needle is not going to be effective. I'm going to need 100 people, so a higher dose to get to that same level. And the thing I tell people to be careful of is make sure it's a direct effect, right? So like alcohol, it's those GABA receptors. That's directly the receptor the volatiles are working on. That's a direct effect. A lot of times where people get tripped up is like um, hyperthyroidism. Well, you can have hyperthyroid disease, but if you don't have the increased cardiac output, you don't have the increased basal metabolic rate, it's well controlled, that is not going to itself give you a higher MAC value. It's all the side effects of it.
Right. So if it's under control, you're not going to have to increase that MAC value, or that MAC value is not going to be increased. Yeah,
Yes.
that makes sense. I like the basal metabolic rate. I think that's a good way for learners to conceptualize it because it's something that we're used to thinking about is anything that can increase that basal metabolic rate since they want to keep us asleep. I love that analogy. That's great. So the next topic we're going to talk about, which is kind of an interesting thing, but basically what I want to do is kind of compare the three agents. I know a lot of the time in 2025, we're using sevoflurane for the most part. I mean, when I started practice, I think they had a halothane in the back just as like an antique item to show students. We were using ISO a little bit more for different cases, and desflurane actually for the bariatric surgeries that we were doing back then. We were using des, and honestly, in the last 5 years in practice, I haven't seen any of those. So I know if I was standing in the OR today, most of us would go towards sevoflurane because that's the most common practice in 2025. But can you talk a little bit about each agent and why you may pick one or over the other if you're working in the OR?
Yeah. So each agent has various properties that make it more ideal for other agents for patients than other agents. So for instance, sevoflurane and desflurane, really fast onset offset, which is great. There's also, we didn't talk about oil coefficients, but that's essentially how lipophilic agents are. So like ISO is very lipophilic in that 99 molecules of it compared to one hang out in the fat. That makes it last a very, very long time after you turn it off, right? Des and Sevo really don't have that. So they need higher doses, but they come off quickly because of the partial coefficients we talked about earlier. They also don't hang out in the lipids, so they don't have that like reserve that just keeps dwindling its way out. So those are very nice for those patients. Sevoflurane also isn't irritating to the airway. So unlike ISO and DES, sevoflurane is a really nice choice for any of your like asthmatic, your hyperreactive airway patients. Kind of helps bronchodilate, calm them down. It's also ideal for those inhalation inductions because it's not irritating to your upper airway. So that's nice for that. Um, Isoflurane, you can use a lot less of the volatile for your anesthetic, which that is nice because of the environmental effects. So there's a wide variety, and I always tell my students kind of be familiar with all of them, but what do you need for this case and kind of what is your goal? Is it a case where you have to do a general to protect their airway, but it's going to be a 15-minute case? And it's someone who is the chronic alcohol user and has uncontrolled hyperthyroid, but it's an emergency and all these things that you're going to need a much higher MAC. You probably want DES, right, to get it on and off really quick to get that turnover time. ISO wouldn't necessarily be ideal. So it really is patient specific. Do you have a bad asthmatic that you were afraid of bronchospasming? Go for SIVO to help you pick out which agent is best for that case.
Yeah, like I said, I've only used DES for bariatric surgery, which makes sense, right? Because it doesn't hang out in the fat as much, so patients don't they wake up faster from our anesthetics. But I have seen desflurane tachycardia. I remember
Yep.
I was a student that using it, and I was like, oh my gosh, like the patients they were making incision, and I was like, oh, the patient must be waking up. They're not deep enough because their heart rate was 120s, and then I realized they weren't moving, nothing was going on. It was because my flows were still at 8 and the gas was still high. So those things happen, and we don't see them as much anymore because again, not a super common agent to use with the heated vaporizer and all the different specificities of it. But that's one memory of DES that I have as a student, like, oh, desflurane tachycardia actually exists. The textbooks are right. So are there any times where you would absolutely avoid one agent or over another? Can you think of an instance or two?
Yeah, so there's two specifically that come to mind that are lesser known pharmacologic effects of these drugs. So one is SIVO is really great, and that's kind of everyone's go-to agent now because less environmental effects, doesn't hang out as long, awesome. Um, but studies have started to show, especially in people prone to seizures, if they have high concentrations of sevoflurane, like you might see with inhalation inductions, you just have to be really careful because it might actually have a reverse effect, and when it's coming off, will re-excite those neurons and cause seizures. So that's come up in a couple case studies, couple animal models. Obviously, we're not trying to replicate that in humans, so we don't know if it carries over to humans, but that is a big deal. And then the other one, so I know especially, I'll say isoflurane is the cheapest out of the anesthetics, right? So a lot of places looking at cost savings might be going more toward isoflurane. Um, the problem with that, though, is they really found there's a strong, strong correlation that isoflurane actually activates enzymes in your brain that contribute to those beta amyloid plaques, and they'll make it for up to 24 hours post exposure. So now there's a lot of animal research that's been done on this, and they're starting to, in humans, again, we're not exposing them to that or trying this out on humans, but they're really recommending if you're someone who's at high risk for Alzheimer's or has a family history of Alzheimer's, where those beta amyloid plaques are really a big problem, to probably avoid isoflurane because it can actually trigger earlier onset or worsen the symptoms of the disease.
Wow, I didn't know that. That's great. And that's why, again, like we're going to talk about a little bit about your research and what you've done with the volatile agents, but that's why it's so important as providers to stay on top of the current literature. I mean, Alzheimer's is a pretty significant disease and it's affected my family, my brother-in-law specifically. But those types of things and research is so important because it does change what the decisions that we make every day in the OR. So I didn't even know that. So that's great for me to know. The next topic we'll go into is more about the carbon footprint. So I feel like in 2025, we're doing a better job of thinking about our carbon footprint than we have in past generations. So this just is getting talked about more, but still not getting talked about enough. So can we talk a little bit about how our choices in the OR, again, kind of impact the planet and give us a brief overview on all of your experience and research in this area?
Yeah, of course. So this is the hot topic in anesthesia right now, right? How our volatiles affect the environment. So all of our volatiles do have very powerful greenhouse gas effects. Um, so CO2 is kind of the main standard, if you will. So CO2 has a greenhouse global warming potential of 1. Okay. Some of our volatiles, lots higher than that. So essentially, because they're breathed in by the body, they're breathed out unmetabolized by the body. Or if they're metabolized, it's very little, only like 0.2% of them, 0.002%. They're released back into the environment unchanged. And that's not great because they do have that greenhouse gas effect. They have potential for ozone layer depletion, especially with chlorine content in some of them. Halothane was really bad for that. Nitrous oxide is not quite a volatile, but we use it alongside that. That's really bad with ozone depletion. Um, so they definitely can impact it. And to give you an example, like I said, CO2 is the one we always talk about, right? CO2 emissions that has that GWP of 1. So desflurane, for instance, has its GWP for 100 years is 2,540. So much higher. That's why you'll probably hear in the literature a lot, avoid desflurane like the plague, right? Like don't use it. It's so bad for the environment. ISO is around 500, so a lot less. SIVO's about 130. So like a desflurane molecule in the atmosphere will last 14 years before it's degraded by the atmosphere and no longer working. Um, SIVO and ISO's around 3 years, SIVO's around 1 year respectively. So less, but still high potential while they are in the atmosphere. Um, which obviously is a problem, right? With the extreme weather and the planet warming. Yeah, so very, very bad. And to put it into context, like real world again, so 1 hour of desflurane anesthesia, if you had a gas, not a diesel, just a plain gasoline car, it's about driving 125, 250 miles versus SIVO is like 6 to 10 miles.
Wow.
So huge, huge difference.
Oh, definitely. Maybe that's why I really didn't know why desflurane was kind of like gone off to the side. It might be more expensive too. I'm not sure on the cost of desflurane. Is it more expensive
Yeah,
than
so
SIVO?
it is slightly more expensive than the
Okay,
others.
so I think the expense mixed with the environmental impacts, hopefully, is the reason why it's kind of not used as much anymore. But that's so interesting to know. So I was going to ask you which is the worst one to use, but it sounds like desflurane takes the cake on that one.
Yes, by far.
So I'm sorry if I missed it, but did you mention nitrous oxide with how
Yeah,
impactful it
so
is?
nitrous oxide, like I said, also, so the others don't deplete the ozone as much. It's just the warming from the reflection from the sun rays, like bouncing back to the planet. They're really bad at that reflection. Um, versus nitrous depletes the ozone. That's kind of its main claim to fame for its environmental impact. So it's right between SIVO and ISO. It's around 300 years. Its atmospheric lifetime, though, is a lot higher than all the rest. It lasts for 114 years in the atmosphere.
Wow.
So if DES is 14, nitrous is 114.
Wow. Yeah, we
So
had a
that
DN
side with other side effects of nitrous is probably why people are again steering away from that.
Yeah, and in my practice, it's interesting because that's a barrier to change, right? Is that people are so used to using nitrous oxide, and especially now that there has like analgesic effects for like OB patients. There's a lot of literature on that now. But in my practice, I hardly ever use it because I got it at the dentist once and it made me puke, and so I'm like, I'm not using this anymore because I don't want to make my patients puke. And then we had a DNP cohort through Kaiser that did a project on the environmental impact of nitrous and tried to convince all 70 plus CRNAs of us to stop using nitrous. And the people that use it day in and day out, it's that barrier to change where they're so used to their wake ups, the timing of it all, and hopefully as the generations go on, we learn that we just don't even need it, and that maybe in those specific instances for analgesia, but the risks and the benefits have to outweigh one another in order for it to be useful.
And I know I get a lot of, because so in Detroit where I practice, we have a lot of low income, Medicare, Medicaid. ISO is the cheapest, so ISO is kind of what they push, right? It's a little
Okay.
worse than SIBO, but not horribly worse. So that's kind of their go-to. But it's so slow because it hangs out in the fat. So nitrous really helps speed it up. Okay,
Yeah.
but are you negating the environmental impacts if you're adding nitrous? Versus just the more familiar you get with it. And I tell my students this all the time, with anything in anesthesia, right? You're a Miller person, try a MAC for a while. Like, make sure you're competent in both. You're used to waking someone up, isoflurane with nitrous, try it a couple times without, just so you get that timing down. But I think it's very hard because people fall into those practice patterns and then they're like, no, unless there's a very compelling reason to change, don't want to do it. It works fine for me. Leave it
Yeah, you
alone.
kind of pigeonhole yourself into practice where you're not used to using other things, you're not comfortable with it. But yeah, I think that's good, even as new grads, to kind of keep doing different things and learning from different practices. Because you're right, it does depend on like the practice where I'm at with SIVO. Like, I don't even know the last time I've seen anyone fill an ISO container because we're bougie, I guess, and we use SIVO more frequently. But with neuro, we were using ISO a little bit more, but now it's just primarily SIVO for the most part. So the practice where you're at definitely affects that for sure. So let's talk about, I guess you've kind of touched on it a little bit, but if you were to give like a top 3 tips for sRNAs and CRNAs to do right now in their practice to make their practice a little bit more eco-friendly, what would you suggest for them?
So definitely drug choice matters. So with the volatiles, if you can go for SIVO, great. If you're just worried about wake up, maybe you do SIVO or ISO for the case and you switch the DES the last 20 minutes, right? So you can tailor it very specifically to your patient. I hear a lot of people talk about TIVA, just avoiding volatiles altogether, which is great. But then with all our one-time use in the hospital, you have a lot of waste. The other thing, so my research primarily, we didn't do so much with volatiles, but we did just pharmacologic substances, IV meds, oral meds, anything that were ending up in the groundwater in the world. And a problem with a lot of those is if we buy, say, I don't know, propofol in 500 milligram vials or, 1,000 milligram vials because you're doing TIVA, but then you waste 800 milligrams at the end because the case ended sooner, you didn't quite. That's not picked up. First of all, it goes into the sewer system, right? Goes to the water treatment plants. There's very few water treatment plants in the world that are designed to take those substances out of the water. So like we did in the Metro Detroit area, we looked at the groundwater. Now we didn't look at it after it was treated by the pilot plant for the groundwater. I do want to state that. But there's been plenty of other studies where we've taken groundwater, looked at the levels of meds in the groundwater. So like metformin, for instance, same, excreted unchanged by the body, mostly. It's the most prevalent drug in groundwater in the world. So we're all getting microdosed with metformin because no water treatment plant is really designed to deal with that. We found contrast chemicals. We found, and definitely as TIVA becomes more prevalent in areas, you can trace that back to the groundwater. Like, oh, now we're seeing increasing Offermev in the water because they're doing opioid sparing and increasing aspirin and increasing gabapentin. And so just, I would say, be very aware. And I love Nagelhout's quote, right? Don't practice trash can anesthesia and just throw everything you got at them. I try to be very specific to the patient and also give myself, especially in maintenance time, right? Really pay attention to the surgery. Do I need to pull out another 1,000 milligram vial propofol, or maybe I get away with a 200 milligram if I think I'm going to be somewhere in between? What's the harm in using a couple 200 milligrams time up to that versus wasting 800 milligrams of a drug? Because there's definitely effects we're seeing. Like I said, we exposed even like transgenerational effects in zebrafish. That's what my lab worked with, because they share 70% of their DNA with humans. So they're an NIH-approved human model. We would expose them to the low levels of meds in this groundwater, and then some of their offspring were having like cardiogenic effects and neuro effects, and from the repeated like micro dosing. So definitely something to be aware of.
Oh yeah, definitely. And I found that like even just working with some CRNAs in the practice that I work at that have been on missions trips and kind of seen world impacts and like place, it's easy in the United States to kind of go like, oh, like those aren't real problems, or like, oh, I can waste this, it's not that big of a deal, and not even think about where the things that you're squirting out are going. It's easy to do that in the United States, but I've noticed that the CRNAs, I haven't been on a mission as an anesthesia provider, and I need to because I think that perspective is important to see worldwide. But I've noticed that they are very mindful of waste in every way, but in terms of drugs as well, because they just don't have those drugs physically. But on top of that, seeing the world impact of it. So, yeah, that's very. You said zebrafish, right? Was your
Yes,
wow?
zebrafish.
I didn't know that about the 70% similarity. That's very interesting as well. I'm learning all sorts of stuff, so I appreciate you. I'm going to do just a few rapid fire questions to close us out here. So some of them will be a little bit redundant, but we'll just kind of go through them at the end here. So what is one thing you wish every SRNA or nurse anesthesia resident knew about our inhaled agents?
I really wish they'd take the time because, like I said, I know clinical sites matter. I know where you practice matters, and I think there's a tendency to like volatiles are volatiles, right? They have the same mechanism of action. They do the same thing, um, but just really learn how to work with each one. And even if you just pick two or three key points, like this is really a highlight of this one. This is a good reason to use it. Um, so that you're not treating every patient the same. You said you get super nauseous. I get super nauseous from nitrous. I would not appreciate anyone using that on me. Um, but yeah, to really appreciate the differences and not just think like, oh, volatiles are volatiles. It's all the same.
Yeah, being mindful. Yeah, with each patient specifically. I agree. That's very important. So again, I guess let's just pick one habit that you wish um, that you would tell CRNAs or SRNAs to do to help with patient care, but also sustainability and that environmental impact.
Yeah, so I would say SIVO is great as the default. If you don't have all the information or, have to make a quick rapid fire choice. But really think about everything you're using and are you using it for something specific for that patient, which I know is redundant. But again, I think even TiVo, right? People are like TiVo and they're like, oh, I have to have propofol or I have to have Precedex and I have to have a opioid and I have to have this or I have to have regional and I have to do all of these meds together. Like my cocktail is these 5 meds and that's what, well, are there overlapping mechanisms? Because if there are, you're not doing much good, right? You're just throwing more at the same problem. Um, so for volatiles, SIVO, that's kind of your go-to, but still learn about the others because they are useful. For Tiva, don't fall into the habit like Tiva, I need 3 different drips running to do Tiva successfully. Maybe they're really cardiovascularly healthy. You could do a nerve block and just a propofol drip and call it a day, right? So just be aware of that as well. Don't feel like you need to add on 4, 5, 6 things to make Tiva successful and at the same level as the volatiles.
Yeah, I think that that's a great point because it was later in my own practice as a new grad where they stopped making sufentanil. And it was like,
Mhm.
oh, okay, now what? And then remifentanil is so expensive, and we have it at my facility. We're like bougie in that way again, I guess. But you have to change the syringe about every half an hour if you're running it at a full Tiva amount. And so, and even Remy we started using it up because everyone was using it. And that was our recipe at our facility. And so now all these providers are thinking outside the box and like, oh, I didn't realize as a new provider that licensed provider, I should say, that you can do boluses instead of the drip. And like, that makes sense pharmacologically, but it just was that classic recipe that we were stuck into. Again, like pigeonholing yourself where you're not comfortable with anything else. So yeah, I agree with you that it's important to try different things and not be so used to the cookie cutter and not thinking outside the box because it is wasteful, like all those
Yeah.
meds.
And then I've seen Remy like same thing, like, okay, well, I can bolus it, which is great. But then if you get the hyperalgesia, you gotta add on mag or ketamine or okay, so could you have just gotten away with ketamine or like is that not the best choice for this patient? Um, or if you're bolusing remifentanil with its half-life being so short, could you just give a cc of fentanyl like every half
Right.
hour to do the same thing, right? But sometimes
Yep.
people are like, oh, Tiva equals Remy.
Hmm.
Okay, but really besides the metabolism, they're acting on the same receptors. The only difference between it and Sufenta or fentanyl is potency. So just up your dose of something.
Yeah, no, you can totally substitute it. And it's like Dr. Nagelhard always said too, is like, keep it simple. Like, why are we making it so complex? Like, you can really keep it simple and minimize side effects or hyperalgesia with just the regular meds like fentanyl. So, yeah, it's great points for sure. So the last question I'm going to ask you is something I'm going to ask every guest that comes on our podcast. And that is, it doesn't have to do with pharmacology necessarily, but just kind of like one tip or word of encouragement. My they are going to have their first semester or second quarter rather, first year of nurse anesthesia school. So if you could give them one piece of advice, what would you give them?
I would say take it a day at a time. It's a marathon, not a sprint. And you will have amazing days in the OR where you're like, oh, nothing's going wrong. I got this. I can do this. And then you won't be able to intubate for 3 days in a row. It happens to everyone. It's okay. Your good preceptors, great. Talk to them as much as you can. Stay in contact with them. They're great even throughout your career. I can't tell you how many people I've been blessed with that have helped me. And the bad days, I always tell my students, okay, take it. You still got through the day. That was a success. And think about that golden rule, right? Treat others how you want to be treated. The students right now, you're in it, and it's long days, and it's hard sometimes, but you're very quickly going to be on the other side, and don't ever forget what it was like. And as long as people are coming to you with a willingness to learn and a work ethic, what else could you ask for, right? Train them up, mentor them, because I think we all could be better at our jobs, and that's the only way is by talking to each other. And what do you do that works? What have you found out? What, and if we raise people who are afraid to do that or don't want to provide that mentorship, you're in the wrong field.
Yeah, no, I agree. And I feel like we all have one or two mentors that have gotten us to where we are today. I can think of so many off the top of my head. And what people forget sometimes in the OR is that, not to turn a negative path, but that these students will become our colleagues. And the world of anesthesia, like, I'm so glad we got to connect today. I would have never met you otherwise. Or maybe at a conference we would have, or, the fact that we both have Dr. Nangelhow as a commonality, like it's such a small world in anesthesia, and what better way to improve our profession than to help raise the future generations? And I mean, both of us saying that is like a little bit biased because we're professors, right? And we love to do that. Not everybody has a passion for education. But yeah, just treating each other kindly and encouraging students. So I guess that's my tip. You had the NAR and the SRNA portion. My encouragement to anyone listening that is an active provider is to help us mentor the next generation. So I think that's...
And I would say, please pick your practice. Like, if you're someone who absolutely knows that, like, to the questions, they can't do it, that's fine. But then please don't place yourself at a place where every room has an SRNA, right?
Yeah.
Like, at least self-reflect and know that about yourself. There's plenty of other places to practice. Because really we need those providers, and they're our future. So we all got to do our part to raise them up.
Yeah, definitely. We all have that. We all have free will and choose a facility without learners, and that's totally fine. And not all of us have the personality, and that's great, but we do. So I really appreciate you logging on today and talking about this. If you guys have any questions for Dr. Phillips, feel free to email me. But thank you. I appreciate your time.
Yes, thank you so much. I love talking pharmacology, so anytime.
Thanks so much.
All right.
Hello, my favorite learners. This podcast is for educational and informational purposes only and does not constitute medical or professional advice. While we strive for accuracy, medicine is constantly evolving, and clinical decisions should always be made based on current guidelines, institutional policies, and individual patient considerations. The views expressed are those of the host and guests and do not necessarily reflect the opinions of any affiliated institutions. Listeners should consult their own healthcare providers before making any medical decisions.